Welcome to Dermatology Discussions. You know the exact scenario we are about to explore today. A patient is sitting on the exam table, visibly terrified. They reach into their bag and pull out a Ziploc bag filled with massive clumps of hair.
Oh, yeah, you see it all the time. Hair they collected from their shower drain, their pillowcase, their hairbrush.
Exactly. And they want a solution today. They want a prescription to, stop the shedding right now. But the medical mystery you are trying to solve didn't actually happen this week. The actual biological insult that caused this terrifying hair loss occurred like 90 days ago.
Right, because we are talking about telogen effluvium. And mastering this condition is incredibly important for the clinical setting, but it is also, one of the most consistently tested topics on the dermatology board.
Oh, absolutely. So to give everyone the high-yield definition right out of the gate, what are we looking at?
Well, telogen effluvium, or TE, is a non-scarring alopecia. It's basically characterized by a massive synchronous shift of a large number of hair follicles out of their active growth phase and straight into their resting phase.
Resulting in that profound diffuse shedding.
Exactly. Which classically manifests 2 to 3 months after some sort of physiological or emotional trigger.
Okay, let's unpack this. Because to truly conquer TE in this discussion, we need a roadmap. We're going to cover the precise biological timeline, the specific clinical and pharmacological triggers you absolutely must recognize.
And the classic physical exam findings, plus the crucial histopathology, because, the microscope is where the board exams will definitely try to trap you.
For sure. And we'll cover exactly how to manage a highly distressed patient. But to understand why a patient's hair is falling out in handfuls today, we first have to understand the immense metabolic engine that is normal hair growth.
Yeah, the hair cycle is a massive energy sink for the body, and it operates in 3 distinct phases. So the primary phase is anagen, the active growth phase. In a normal, healthy scalp, a staggering 85 to 90% of hairs are in this phase at any given moment.
Which is a huge metabolic demand.
Huge. These follicles are rapidly dividing, building hair shafts millimeter by millimeter, and they sustain this nonstop activity for years, typically 2 to 6 years. Following anagen, the follicle enters catagen.
Which is just a brief transitional phase, right?
Exactly. It's a regression phase lasting just a few weeks where cell division completely stops. Only about 1 to 2% of hairs are in catagen. And finally, the follicle enters telogen, which is the resting phase.
I always visualize this normal cycle like a massive bustling factory. Anagen is your active assembly line. You have 85 to 90% of your workforce on the floor, happily building hair shafts day in and day out.
I love that analogy. And telogen represents the 10 to 15% of workers who are just, taking a scheduled break in the break room.
Right. They sit there resting for about 3 to 4 months before the hair is naturally shed and they go back to the assembly line.
Mm-hmm.
But acute telogen effluvium is a completely different scenario. A systemic trigger hits the body, acting like a sudden blaring fire alarm in that factory.
And that alarm forces a massive number of those active workers to abruptly drop their tools, clock out, and run straight to the break room. In acute TE, that normal 10 to 15% resting count violently spikes.
Wait, up to what?
Up to 20 to 50% of all follicles entering telogen simultaneously.
Oh, wow, that is wild. And the biological mechanism behind that fire alarm is fascinating. When a severe trigger hits the body, like a prolonged high fever or a major surgery, the body mounts a systemic inflammatory response.
Right. It releases a flood of cytokines, specifically interleukin-1 and tumor necrosis factor, or TNF, into the dermis.
And these cytokines directly target the hair follicle. They act as inhibitory signals that instantly halt proliferation and trigger premature apoptosis. Program cell death of the matrix keratinocytes.
Mm-hmm.
The assembly line is immediately shut down.
Here's the concept that consistently trips up medical students and even seasoned residents. The hair does not fall out when the assembly line shuts down.
It doesn't.
No, it doesn't. The trigger forces the follicles into a shortened catagen phase, and then they transition into the telogen resting phase, and they just sit there. They are fully anchored in the scalp as club hairs for 8 to 12 weeks.
Okay. So that 8 to 12-week period is simply the mechanical transit time it takes for the follicle to rest before the active release, the exogen phase occurs.
Precisely. So the shedding the patient experiences today is just the physical echo of a biochemical fire alarm that rang months ago.
Let's cement this timeline, because it is the golden rule of this condition, both in the clinic and on the boards. The delay between the systemic trigger and the actual hair shedding is always 2 to 3 months.
I cannot stress this enough. 8 to 12 weeks, 2 to 3 months. When you are taking a patient history and they are shedding profusely, asking them what happened last week is a total waste of time.
Right, you must ask them what happened 2 to 3 months ago.
Yeah.
That timeline is the single most important diagnostic discriminator between TE and other rapid onset alopecias. So if we know the hair is just sitting there in the telogen phase for 3 months, basically the obvious question for the clinician is, well, what pulled the fire alarm 90 days ago? We need to look closely at the triggers.
Because the boards love to present a patient vignette and expect you to connect a specific life event or medication to the sudden onset of diffuse shedding, the triggers for acute TE fall into a few distinct testable categories.
Starting with physiological stress.
Right. We are talking about major systemic shocks, a high fever, a major surgical procedure, severe illness, or a prolonged hospitalization. The body is essentially triaging its resources.
Shutting down the non-essential metabolic demand of hair growth to focus on vital organ survival and healing. So what's the second major category?
Endocrine triggers. And the absolute classic here is the postpartum state.
Postpartum TE is so incredibly common. I mean, it occurs in 40 to 50% of women after childbirth, and the mechanism is entirely hormonal.
Right. During pregnancy, elevated maternal estrogen levels act as a powerful growth stimulant for the follicles, essentially locking them into a prolonged anagen phase. So the hair looks thicker and fuller than ever.
But immediately after delivery, those estrogen levels plummet. That sudden hormonal crash is the fire alarm. It causes a massive synchronized exodus of follicles from anagen into telogen.
And true to the biological clock we just established, the profound shedding happens exactly 2 to 3 months after delivery. Beyond postpartum changes, though, you also have to evaluate for thyroid dysfunction.
Like hyperthyroidism, right?
Exactly. Both are well-documented endocrine triggers. Then we move into nutritional and psychological triggers. Severe protein starvation, zinc deficiency, crash dieting, rapid weight loss, and profound emotional trauma can all initiate that cytokine cascade.
Wait, hold on. If trying a new extreme diet or, having a really stressful month at work can induce this, shouldn't half the population be walking around shedding their hair? I mean, how severe does a trigger actually have to be?
That is a vital clinical distinction. Acute TE requires a discrete, significant systemic event to overcome the follicle's natural resilience. Every day, minor psychological stress does not cause acute TE.
So a bad day at the office isn't enough.
Right. The systemic shock has to be severe enough to disrupt the massive energy allocation of the hair cycle. When that severe acute trigger occurs, the shedding is sudden and, by definition, lasts for less than 6 months.
Which brings us to the slip side of that, chronic TE. This is defined as diffuse shedding that persists beyond 6 months, sometimes dragging on for years.
Yeah, and this notoriously affects middle-aged women, typically between the ages of 30 and 60. And chronic TE is incredibly frustrating because, unlike the acute form, there is frequently no obvious fire alarm to point to.
So it's frequently labeled as idiopathic, right?
It is, but you cannot simply slap the idiopathic label on a patient without doing your due diligence. You must investigate and rule out chronic, low-grade systemic issues that might be keeping the follicles trapped in a resting state.
Things like chronic iron deficiency. You specifically want to look for a ferritin level below 40 nanograms per milliliter, right?
Exactly, though some experts recommend a target of 70 for optimal hair growth. And you also have to rule out smoldering autoimmune conditions like chronic thyroiditis.
Before we move off triggers, we definitely need to talk about the prescription pad, because drug-induced TE is prime board exam territory. What are the must-know medications?
The drugs you absolutely must recognize as triggers are the retinoids, like acitretin and isotretinoin beta blockers, anticoagulants, and anticonvulsants, specifically valproate.
Okay, so if a clinical vignette describes a patient starting valproate for seizures or a beta blocker for hypertension 8 to 12 weeks ago, and they now present with diffuse shedding.
Boom. You are looking at drug-induced telogen effluvium.
Okay, so having identified the vast array of triggers, we need to focus on what this actually looks like when you walk into the exam room. The clinical picture is highly specific, despite being a diffuse process.
Yeah, as we mentioned, the patient is usually highly distressed, bringing in physical evidence of the shedding. When you examine the scalp, the thinning is entirely diffuse.
You will often notice that the bitemporal and vertex regions look slightly thinner, and the part line might be mildly widened. But here's the critical negative finding. There are absolutely no complete bald spots.
None. The hair density might only be reduced by, say, 30%. More importantly, the frontal hairline is completely preserved.
Which is a massive diagnostic clue. It differentiates TE from androgenetic alopecia, where you would expect to see distinct bitemporal recession or frontal thinning.
Right. And because the overall density reduction is relatively mild, the sheer volume of daily shedding is often much more noticeable to the patient in their shower drain than it is to the clinician looking at their scalp.
Which makes the physical examination paramount, specifically mastering the hair pull test.
Yes. The pull test is how you prove that the active shedding is happening right now. To perform this correctly, you don't just grab a few hairs. You need to firmly but gently grasp a bundle of about 40 to 60 hairs near the base of the scalp.
And then you apply consistent, gentle traction as you slide your fingers all the way up the hair shafts.
Exactly. If you extract more than 3 to 5 hairs from that bundle of 60, the test is positive. But a positive test isn't just about the number of hairs, it is about examining the proximal end of the hairs you just pulled out.
I always describe a positive TE pull test like picking a perfectly ripe apple off a tree. If that apple is ready to harvest, it comes away effortlessly, cleanly, with the stem completely intact.
That's a great visual. When you pull a telogen hair, it comes away easily, and you will see a clean, white, club-shaped bulb at the proximal end. There is no tissue attached to it. There is absolutely no sticky, gelatinous root sheath surrounding that bulb.
And examining that bulb under a dermatoscope or even just good lighting immediately rules out the major clinical mimics. Take loose anagen syndrome, for example. This is a condition that typically presents in young blonde children.
Right. The hair pulls out completely painlessly, just like TE. But if you look at the root of a loose anagen hair, you will see a ruffled, gelatinous root sheath attached to it. You are pulling out an actively growing anagen hair that has a defective anchor, not a resting telogen club hair.
You also have to differentiate it from Telogen Effluvium, which sounds similar phonetically but is an entirely different beast in terms of timing and biological mechanism.
Oh, completely different. Anagen effluvium is the result of an immediate catastrophic toxic insult to the follicle. This is classically caused by chemotherapy drugs, which are potent antimitotic agents.
Because they circulate through the blood and directly halt the rapid ongoing cellular division of the matrix keratinocytes in the anagen phase.
Exactly. Because the growing cells are poisoned, the actual hair shaft becomes structurally weak and breaks off. Shedding occurs just days to weeks after chemotherapy exposure, not months. And if you examine those hairs, they won't have a clean white club. They will have tapered, fractured, or distinctly dystrophic anagen roots.
Okay, so clinically, we have a patient with diffuse thinning, a preserved frontal hairline, a positive pull test yielding clean white bulbs, and a clear history of a systemic trigger 90 days ago.
Yeah.
In that classic scenario, the diagnosis is clinical.
Yes, exactly.
But what happens when the shedding is chronic, the trigger is a complete mystery, or you suspect early female pattern hair loss is muddying the waters. That requires tissue. We have to look under the microscope, and dermatopathology is heavily emphasized on the board exams.
Right. Now, biopsies are generally not recommended for classic acute TE. The trauma and cost aren't justified when the clinical picture is clear, but for chronic TE, or to definitively rule out the mimics we just discussed, a scalp biopsy is the undisputed gold standard.
Here's where it gets really interesting, though. If this is just a resting phase issue, why on earth would we do a biopsy? Aren't we just going to see normal skin?
Well, we biopsy to rule out mimics, like I mentioned, but for the boards, you must know that horizontal sectioning of that biopsy is absolutely mandatory.
Let's explain why horizontal sectioning revolutionized dermatopathology. If you take a standard punch biopsy, which is essentially a tiny cylinder of tissue, and you slice it vertically down the middle like you would for a normal skin rash, you're only going to see a few hair follicles that happen to get caught in that specific vertical plane.
Right, you can't assess the overall density or the ratio of growing to resting hair.
But if you take that cylinder and slice it horizontally, parallel to the surface of the skin, it is like looking down at a dense forest canopy from a helicopter. You get a perfect cross-section.
Yes. You can literally count every single follicle in that sample and precisely determine what phase of the hair cycle each one is in. And that ability to count is how we establish the diagnosis.
Which brings us to the magic numbers.
Right. We established earlier that the normal telogen count on a healthy scalp is 15% or less. The absolute diagnostic threshold for telogen effluvium on a horizontal biopsy is a telogen count exceeding 20%.
Oh, wow. So the normal anagen-to-telogen ratio of 85 to 15 completely inverts, dropping to less than 4 to 1?
Exactly. But the board exams will not just ask you to identify a telogen count of 22%. They will present a slide and ask you to differentiate TE from other conditions based entirely on what is absent from the tissue.
And there are 3 key histopathological discriminators you must sear into your memory. Let's repeat these for the listener. Number 1, absolutely no miniaturization.
Right. Every single follicle in a pure telogen effluvium case is of normal, robust size. They are resting, but they are not shrinking. If you look at a horizontal section and you see a phenomenon called hair diameter diversity greater than 20%.
Meaning you see a chaotic mix of thick, healthy terminal hairs alongside tiny, shrunken, vellus-like hairs.
Exactly. If you see that, you have crossed the line into androgenetic alopecia. AGA causes progressive miniaturization of the follicle. TE does not.
Discriminator number 2, absolutely no inflammation. If you were looking at the bulb of the hair follicle on a slide and you see a dense bulbar lymphocytic infiltrate.
A visual the boards frequently describe as a swarm of bees attacking the follicle.
Yes, that swarm of bees. You are not looking at TE. That swarm of bees is the hallmark of alopecia areata incognita, which is a diffuse inflammatory form of alopecia areata that can clinically mimic TE. Telogen effluvium is a non-inflammatory condition.
And discriminator number 3 is normal sebaceous glands and an absolute lack of dermal fibrosis. The absence of fibrosis immediately rules out scarring alopecias, like lichen planopilaris or centrifugal cicatricial alopecia.
Plus, because the follicles in TE haven't miniaturized, the sebaceous glands look completely normal and proportional. In AGA, the follicles shrink so much that the sebaceous glands suddenly look massive by comparison.
Just to quickly round out the histopathology, let's touch on some specific immunohistochemical stains that might appear on a challenging board question.
Like Chi-67.
Right. Chi-67 is a well-known cellular marker of active proliferation. If you stain a TE biopsy, Chi-67 will be heavily expressed in the actively growing anagen follicles, but it will be completely absent in the telogen follicles.
Confirming they are in a state of cellular arrest.
Exactly. Conversely, if you catch a follicle transiting through that brief catagen phase, markers like tunol or caspase-3 will be strongly positive, highlighting the rapid accelerated apoptosis of the matrix cells.
Okay, so we have established the timeline, identified the triggers, mastered the pull test, and analyzed the horizontal histology. The final step is returning to the exam room to treat the terrified patient sitting in front of you. So what does this all mean for the prescription pad?
Well, the prescription pad can be a very dangerous tool when dealing with a vulnerable patient who is losing their hair. The core strategy here isn't necessarily reaching for a complex drug. It is identifying and removing the trigger.
Fixing the systemic environment so the follicles can recover.
Identifying the trigger is the entire battle. If the shedding is caused by Valproate, you work with their neurologist to stop or change the offending drug. If their thyroid-stimulating hormone is off the charts, you correct the thyroid dysfunction.
And if their ferritin is sitting at 12 nanograms per milliliter, you initiate aggressive iron supplementation and aim for a target of 40 to 70.
Exactly. But consider the classic acute case. A woman comes in with massive shedding 3 months after delivering a healthy baby. Or a patient comes in shedding 90 days after a week-long hospitalization for pneumonia.
Right, the pregnancy is over, the infection is completely resolved, the trigger is already gone.
In those acute scenarios, the treatment is purely education and reassurance. It is the do-nothing rationale. For acute TE, the condition is completely self-limited. The biological fire alarm has already stopped ringing.
So the massive cohort of follicles currently resting in telogen will eventually re-enter the anagen growth phase on their own. The hair will naturally regrow in 3 to 6 months without any medical intervention.
Yes. But telling a patient who is actively watching their hair circle the shower drain to just go home and wait 6 months is incredibly difficult. They are terrified they are going permanently bald.
Yeah, they will often beg for a prescription, they will ask for topical minoxidil, or worse, they will ask for a course of topical or intralesional corticosteroids just to do something to stop the shedding.
And yielding to that pressure is a massive clinical pitfall. Corticosteroids are absolutely contraindicated for telogen effluvium. We just proved under the microscope that there is zero inflammation in TE.
Exactly.
Corticosteroids are powerful immunosuppressants designed to treat inflammatory conditions like alopecia areata or acute lupus flares.
Mhm.
Prescribing steroids for TE exposes the patient to scalp atrophy and systemic absorption risks with absolutely zero therapeutic benefit.
And what about minoxidil? I mean, patients can buy the 5% foam over the counter. Should we encourage them to use it?
Minoxidil is a complex discussion. It works as a potent biological modifier that prolongs the anagen phase and stimulates resting telogen follicles to re-enter anagen more rapidly. However, you must meticulously set expectations.
Because applying minoxidil today will not stop the hairs that are already locked in the telogen phase from falling out.
Right. In fact, minoxidil can sometimes cause a temporary initial shedding as it forces new hairs to grow and push the old club hairs out. We generally reserve minoxidil for chronic TE, where we are trying to force a sluggish hair cycle back into a growth phase.
Makes sense.
For classic, acute TE, with a clear resolved trigger, aggressive treatments, extensive lab panels, and biopsies are simply not recommended. Time and reassurance are your only proven tools.
All right, let's do a rapid-fire recap of the most testable concepts we have covered to lock this in for the boards. Number 1, the clinical presentation is diffuse shedding, characterized by a preserved frontal hairline and a complete absence of entirely bald patches.
Number 2, the absolute holy grail. The massive shedding occurs exactly 2 to 3 months or 8 to 12 weeks after the systemic trigger.
Number 3, under the microscope on a mandatory horizontal section, you will see a telogen count exceeding 20%, with normal follicle size showing no miniaturization and absolutely no inflammation.
And number 4, memorize your triggers. Specifically, the massive hormonal shifts of the postpartum state and drugs like retinoids, beta blockers, and Valpro.
Those are the core pillars that will allow you to confidently diagnose and manage this condition. But before we finish, let's talk about a lingering scientific mystery regarding chronic telogen effluvium.
Yeah, we continuously classify it as a diagnosis of exclusion. We confidently label it idiopathic when it persists in middle-aged women for years without an obvious glaring cause.
But biologically speaking, is it truly idiopathic?
That's the question. Or are we simply lacking the high-resolution diagnostic tools required to detect subtle, low-grade systemic inflammatory cascades, microscopic nutritional deficits, or cellular metabolic triggers that are keeping these follicles trapped in a perpetual resting state?
Wow.
Could the idiopathic label just be a reflection of the limits of modern medicine?
That is a fascinating concept and definitely a perspective to keep in mind the next time you are evaluating a frustrated chronic TE patient in the clinic.
Hmm.
Keep questioning those idiopathic labels. Like, subscribe, and share for more content like this.